today are just to briefly review ACEs and how they impact the concerns that we see in primary care. We'll then explore an example of how this ACEs assessment and intervention can be integrated into a busy patient-centered medical home. And then we'll discuss some of the resources that we found helpful to our targeted population of pregnant women and parents of children 5 years and younger. And lastly, we'll explore some preliminary data, including the frequency at which we observe high ACEs scores, and then also some clinicians' perspectives and patients' perspectives on the SCANS project. With that, I'll turn it over to Dr. Dempsey to review ACEs.
Hello and welcome. My name is Dr. Dempsey. Here on the screen you can see the 10 major categories of adverse childhood events, and it's important that we understand that ACEs can include a variety of individual or repeated events that can occur within one or many of these categories. ACEs are now considered a public health problem, not just a psychosocial problem, due to the research that having 4 or more ACEs tends to tip the scale towards much greater risk of health problems. So how does this happen? We know a lot more than we used to about how chronic toxic stress influences our body. Chronic and toxic stress means that our body is living in a state of constant fight or flight, a red alert state, for months or even years. In this red alert state, the body pumps out large quantities of adrenaline and cortisol continuously. Over time, the constant presence of this adrenaline and cortisol begins to affect the immune system, heart and circulatory systems, and the developing brain, especially in children. Newer ACE models are emerging that will more fully take into account changes in the body that are enduring, a permanent result of ACEs at a time of rapid brain and physical development, aka childhood. Children who are exposed to ACEs have smaller volume of the prefrontal cortex and an elevated inflammation level in their nervous, endocrine, and immune systems. This disruption in neurodevelopment leads to social, emotional, and cognitive impairment, which then predisposes that individual to adopting high-risk behaviors. We know that this causes earlier and/or increased disease and disability, as well as social problems, and then early death. This is a whole life, conception to death understanding of the impact of ACEs on childhood and adulthood health. Speaking of early deaths, people with 6 or more ACEs die nearly 20 years earlier on average than those without any. Although SCAN assesses adverse childhood experience of parents here at our clinic, you may indeed be seeing patients and children who have both been exposed to trauma, and it's important to recognize some common symptoms, many of which are easily misdiagnosed or ignored as psychosomatic complaints. And then as our picture kind of demonstrates, acknowledging that many of these patients are very isolated in dealing with their increased load of health problems. From a mental health standpoint, you can see anger, anxiety, depression, tantrums, other forms of acting out, nightmares and sleeping difficulty, and chronic headaches. From a cardiovascular stance, we look at heart palpitations, high blood pressure, increased risk of hyperlipidemia, and increased risk of coronary artery disease. Higher rates of acne or concerns for acne, and musculoskeletal, you can have muscle tension and aches, specifically backache, shoulder, neck aches, and an increased risk of low bone density. You may see constipation with or without abdominal pain and or diarrhea in any combination, as well as heartburn, weight gain, and appetite changes. From an endocrinology standpoint, women may notice irregular and painful periods, decreased libido. Men may be impotent, have low sperm counts, and also decreased libido, and you have increased risk for diabetes. There's also an overall impairment in your immune system. You may have a longer recovery from common illnesses due to your impaired ability to fight these infections, and that ranges from anywhere from the common cold all the way to more serious illnesses. Having patients' ACEs scores in the medical record will help with the more accurate assessment and diagnosis of your patient. These are some of the most common health conditions in relation to ACEs. Having 4 or more ACEs doubles the rate of stroke, heart disease, cancer, and COPD in adults. Diabetes is 1.5 times more likely among adults with 4 or more childhood ACEs compared with having none. And not shown on this graph, but if you have 4 to 5 ACEs compared to a control group of none, you're at a 3-fold increase of chronic headaches and have double the rate of hospital admission for any cause. I'm now going to pass it back to Dr. Leckie to discuss how we reduce ACEs.
We find that when parents know about the powerful impact of adversity on development, they can be more compassionate with themselves and can better protect their children from accumulation of ACEs. Parents who experienced a lot of adversity as children deserve to know that these experiences may make parenting more difficult. Parents have the most power for dramatically improving the future of the public's health because they have the best opportunity to protect children from accumulation of adverse childhood experiences. Explaining this to parents is as simple as saying, we tell all of our patients about this information because we are trying to help children not have these difficult experiences. In addition to awareness, education, and support, early intervention is also helpful in reducing ACEs. We know that the opportunity for prevention exists. We know that evidence-based parenting programs are effective, particularly when children are young. Parenting programs for families with young children increase attachment and bonding, keep children safe from maltreatment, and help parents help their children flourish. We also know that a comprehensive community-based approach can be helpful. This can be as simple as parents receiving the message about ACEs in multiple places, particularly in places where they have relationships with people whom they trust, such as the primary care clinic. Lastly, we know that building a relationship with patients and showing that you have belief in their strengths can be helpful. And this can be as simple as intervening in a way just as simply as listening. Why did we choose to focus on ACEs at Southern Colorado Family Medicine? In part, it was because of the health status of Pueblo County. To give you an example, in the context that we know that population health and the occurrence of ACEs are issues, Pueblo County ranks 49th out of 59 Colorado counties in length and quality of life, 53rd out of 59 in social and economic factors, and Pueblo County has double the rate of high-risk births and smoking during pregnancy compared with other counties. We know that ACEs occur at every socioeconomic level. Furthermore, because the effects of ACEs can be pervasive and lifelong, our primary care family medicine clinic is an ideal setting to assess and address this topic. To provide some more context to our setting, the SCFM clinic was designated as an essential community provider in 1998. As such, SCFM delivers services to patients of all ages, regardless of their insurance coverage or their ability to pay. We accept Medicare and Medicaid, as well as third-party and private insurance carriers, and we're one of 2 Pueblo area programs authorized to coordinate services through the Colorado Indigent Care Program. Furthermore, we're a duly accredited family medicine residency for MD and DO physicians. We're an NCQA Level 3 patient-centered medical home, and our clinicians are made up of 5 physician faculty and 1 director of behavioral science, 17 resident physicians, a mix of DOs and MDs, a nurse practitioner and a physician's assistant, 1 full-time integrated behavioral health clinician, and then 1.5 integrated healthcare coordinators who help primarily do things like case management and help us provide social interventions for patients in need of them. We have a patient load of about 10,000, which translates to 17,000 patient visits a year, and it's primarily an urban, underserved population. 60% of our patients are Hispanic or Latino, and 3% speak Spanish only. In order to implement ACEs assessment in our clinic, we spoke with multiple programs and other people who were engaged in ACEs research and or using ACEs assessment in their own practice. We searched for models which we could replicate and adapt to our own setting. Unfortunately, what we found is that there aren't really models for adapting and intervening based on ACEs assessment. In that case, we had to create our own, which is how we came up with the SCORE, Connect, and Nurture program. The primary goal of SCAN is to increase the number of families who receive targeted preventive services aimed to reduce the number of household ACEs to which young children are exposed, thereby reducing their and their parents' risk for long-term health conditions. Primarily, we're grant-funded at present as a pilot program. To give you an overview of the SCAN program, one of the primary mechanisms behind it is integrating knowledge and awareness of the health risks associated with exposure to ACEs. And we do this in our primary care setting, but also in our relationships with patients and providers. To do so, SCAN targets three major areas: families, which we do by educating parents and increasing awareness by implementing ACEs assessment in our encounters with families, as well as increasing our own organization's capacity to engage with families about the social determinants of health. We do this by providing training and support for our clinical staff in order to integrate SCAN into the clinic's internal management and practices. And lastly, we work through community partnerships, particularly with evidence-based community services that will reduce children's exposure to ACEs. On a more practical level in our clinic, the SCAN model looks similar to this. The idea behind it is that in order to reduce the risk of health conditions by reducing children's exposure to ACEs, our process involves scoring parents' ACEs and resilience, connecting them with needed resources and evidence-based practices, and nurturing them through a supportive and engaged healthcare environment. We believe that opening the conversation with parents about their family of origin in a way that emphasizes their strengths and resiliency will help them to self-reflect and feel empowered to help prevent ACEs occurring for their own children. In the connection with physicians, parents will receive information and support concerning parenting, child health, family health, and self-care. And then lastly, we have a part-time family resource specialist who is embedded in our clinic to assess families for their ACEs and resilience, help them to access clinical and community resources based on their needs, and also who provides follow-up monitoring. In order to successfully implement SCAN, we know from implementation silence, which is the practice of implementing something new in an organization or setting, that we had to have certain things in place in order for us to be successful. This includes a shared vision, staff in multiple roles making decisions about how to implement it, someone who champions it, and a structure that supports and sustains this effort, and indeed one that is adaptable to any changes that we needed to make. One of the primary ways that we sought to meet these goals was to educate our clinical staff about ACEs and our new SCAN project. This included the education of all associates, from the front desk to the physicians themselves. At the first level, we increased everyone's knowledge of what ACEs are and how we can promote trauma-informed care across the clinic. This helped us to increase the buy-in and investment that people across the clinic would have. As part of this level 1 training, we provided an optional ACEs assessment to all of our associates. This was voluntary and anonymous, and we looked at the data in aggregate in order to give our clinical associates and ourselves a better idea of how pervasive ACEs are, and really to help normalize that ACEs are not just something that our patients experience, our coworkers and even we ourselves have experienced them. And I think it also helped to standardize that this is something we're asking our patients to do. We definitely paired this with information about our company's employee assistance program so that if any of our associates needed to access additional resources, they were familiar with what was available. Our second level of training focused mostly on the clinicians and centered on providing skills for how to approach patients about their ACEs summary score, how to start that conversation and be sensitive to their experiences. Next, our lead clinical supervisor, Jody Hasenak, is going to explain how the other aspects of our SCAN project fit in.
Hello and welcome. Our initial goal for this project was to screen 400 families within the first year. 100 of those were going to be new parents and 300 families with children aged 0 to 5. Our community partner was we partnered with Catholic Charities, so we would have the integrated family resource specialist embedded within our clinic. This individual is responsible for scoring the patients, connecting them with the community resources, and then communicating the assessment findings back to the provider. The provider then has the opportunity to discuss those results further during the clinic visit. The family resource specialist creates that trusting relationship with our patients that is imperative to the success of this program. Our targeted families, we placed our focus on parents of children 0 to 5 and also focused on obstetric patients. Knowing that we only had a part-time integrated family resource specialist available, we had to come up with some ways that we could screen the most people possible with the time restraints that we were faced with. So we decided we would implement a well child check clinic that would take place once a week, and we would capture that intended pediatric population. We also decided to screen all of our new OB patients during the initial intake visit, and then as well as at our twice-weekly high-risk OB clinic. The Integrated Family Resource Specialist is responsible for assessing patients during our well child check clinic and the high-risk OB clinic. The initial OB intakes were assessed by me during the intake process. Here is the actual the ACEs assessment tool that we use in our clinic. Patients are scored on 10 different categories of adverse childhood events. Each yes equals 1 point. The screening process is started by explaining the background of ACEs and informing the patients about the health risks associated with a high ACEs score. The screen is done on a voluntary basis only. It is important for the families to know that the adverse childhood experiences can affect parenting and can affect their health, and that one of their most trusted partners is their provider. Our packet includes a cover letter explaining the program, the research, as well as the assessment. We allow time for the patient to read the letter and fill out the assessment. We'll also read it to them if they're unable to do it themselves. The assessment is scored and then passed on to the provider. We also felt it was extremely important to involve a resiliency screen so we could understand our patients' ability to bounce back from some of these traumatic events, as well as to make them understand that difficult and adverse experiences are not the only events that shape us, and that their ability to cope can be even more powerful than the difficult experience itself. Here's a list of some of those common community resources that we refer to. Parents are offered resources regardless of their ACEs score. Catholic Charities are able to offer a lot of help with rent assistance, utility assistance, diapers, clothing vouchers from our local thrift shops, food assistance from food banks. They help them fill out applications for SNAP or food assistance applications, as well as individual and couples therapy. We refer to parenting programs that are all evidence-based and that are aimed at preventing or reducing child maltreatment. For example, Bright Beginnings is a teaching program that gives you 3 packets for your children aged 0 to 5 that focus on child development or meeting early milestones. Nurturing Parenting is a family-centered parenting course that's good for single, teen, or co-parenting families. The Nurse Family Partnership is a program for first-time moms where an RN follows the patient through their pregnancy and up until the ages of 2. Safe Care Colorado is a weekly home visitation program that offers skills and training for families of children aged 0 to 5. I'm now going to hand it back over to Dr. Leslie Dempsey so she can discuss the clinic implementation and the clinic workflow.
So, as our pilot project was implemented, we brought in the family resource specialist on our well child check day, as Jody discussed. They could mostly focus on one provider's schedule, but they did occasionally see patients from other providers' schedules as they were able or as it was needed. Our goal was for this person to see families prior to the provider. And while this worked out most of the time, it did occasionally cause a delay in the provider visit and some aggravation from our residents. We also learned that if the family resource specialist does not tell the provider the ACE score, it can't be reinforced or impact the provider's care in any way. Lastly, our largest struggle was with the electronic health record. There was no easily documentable place for an ACE score so that we knew which families had been screened or so that we could see their score at subsequent visits to know if they followed up on referrals. Part of this was because we opted not to scan in their actual ACE assessment into the chart. We documented their score and the resources that they were referred to on a summary sheet, but we allowed the personal nature of the ACE assessment itself to remain confidential, and the patients could bring it up with their provider in detail if they so wished. I think this improved compliance and buy-in from our patients because they felt like things were more anonymous. It also was well received in that format by our residents because then an ACE score is an objective finding instead of a patient's story that they have to listen to. So despite all these difficulties, we learned a few good points. All it takes to make this work is a provider or someone on that provider's team who's willing to address ACEs as a routine part of their visit, perhaps in the social history, and a knowledge of available resources. We had several faculty providers who were able to administer the screen themselves with little difficulty, and they felt that they gained great clinical insight into the family and the child's health. That being said, there is such a thing as ideal workflow that we continue to work towards as we move forward. The screen prior to the provider, or the assessment prior to the provider. This allows the family to be calm, they're often waiting, and the children are often less upset, especially compared to if you're trying to do this after shots. This also allows the provider to close the loop of communication and care if the score is known and reaffirmed. Our goal is to create a special place in the health maintenance versus the social history tab where we can input the ACE score into our electronic health record. As I discussed, we will continue to not scan the actual assessment itself, but that may change at a later date. It would also be easier to determine if a family was actually utilizing the resources we referred them to and noticing improvement if we had better continuity and a shared communication system with our community partners. Continuity is always difficult in a residency clinic, and then as we're not on the same documentation system as our community partner, we rely solely on word of mouth at times that we're together. Finally, the most important piece to ideal workflow that we've learned is an embedded assessor. Just like having behavioral health embedded, having someone trained and comfortable with ACEs is ideal. It has the least amount of impact on provider workflow this way while still improving patient care and the patient-provider relationship. The family resource specialist, which may be a social worker, a case manager, etc., their goal is to influence parents to take the next step through engaging, educating about the link between ACEs, parenting, and health, and connecting them with those resources. They're able to reduce barriers. Partly it's simply a warm hands-off, which improves compliance. They're also able to discuss barriers to participation and hopefully overcome those. Lastly, they can connect ACEs and health for the patient and the provider. It can prepare them for their physician's visit. They can be thinking about what they want to ask their physician, if there's anyone else they want or need to talk to, and it lets them know that their physician is on board with addressing this as part of their health care. When we polled our residents for their thoughts on the SCAN project, it was overall positive. Their general consensus is that we had no patients who were upset about being assessed. We had very few decide not to take part in the assessment itself. From their clinical perspective, one resident thought it made it easier to address difficult issues. There was more opportunity for the patient to bring it up instead of us having to ask very direct and pointed questions. He felt that it improved the patient-provider relationship to the point as if he were actually the one to have performed the assessment himself. He also stated he couldn't imagine doing well-child checks without ACEs or some form of trauma-informed primary care because it speaks to the mental health, behavioral issues, child-parent relationships, and their medical health. Another resident who participated stated that the patients who really needed the resources seemed very appreciative of both those and the assessment itself. And it was positive that these, quotation, social issues were already addressed for him. We had another resident who felt like having the ACEs assessed by someone else, the embedded family specialist, instead of them, improved the overall tone of the visit, and felt that patients were less irritated when they were running late as someone had already been in the room with them. Most of our negative feedback from residents was workflow related, as we discussed, the potential delay with the family resource, them feeling like they needed to interrupt or not getting the score reported. Jody will now fill us in on some of her perspectives.
I personally feel that this screening process has made it much easier for me as the OB case manager to ask some of these more difficult questions that had to be addressed during the initial intake process. I'll be honest, I was totally guilty of reading directly from the social history section of the patient's chart. I would ask them word for word, any past history of physical abuse, sexual abuse, emotional abuse, and I would just hold my breath hoping that they would say no. I wanted to be compassionate and provide more support for my patients, but I truly did not know what to say. I feel like this process has made it so much easier for me as a nurse to discuss some of these issues. I now introduce the SCAN program during the patient's assessment while I'm doing their social history. I feel like it's made it a lot easier for me to bring some of those things up, and I feel like it empowers the patient to be able to take control of their future, knowing that they can have a positive impact on their soon-to-be-born child. Here's one of our success stories. I've recently had the pleasure of being part of a SCAN success story. We've encountered a couple during the OB intake. They were faced with so many challenges. They just moved here from Colorado. They had absolutely no family. They were expecting their first child, and their apartment was not livable. It was in the process of being condemned. She was not working, and he had just lost her job. They scored a 9 and a 10 on their ACEs assessment. So from the help of the family resource specialist, we were able to find him a new job. We found them a new apartment that was much safer to bring a new baby into. We enrolled them in Safe Care, Bright Beginnings, and Nurturing Parenting, as well as they had started therapy sessions. It's truly amazing to see the impact that this program has made on some of our patients. I'm going to go ahead and hand it over to Dr. Julie McCrae so she can discuss some of those preliminary data that we've collected this far.
Thank you, Jody. We are collecting all of the SCAN assessments along with demographic information and the resources that families have been referred to through a web-based database. We have assessed 134 families since October of 2015. That 115 should be 134. So that's about 5 months into the program, and the assessments have increased over time as we've gotten better about our flow and where the family development specialist is coming in to conduct the assessments. We assess all adult family members that come in for the patient visit. So that can include a father or a partner or a mother or potential mother. We have a few grandparents that have been assessed for their adverse childhood experiences. And again, this is all voluntary, but so far they have been very open to doing that. You can see the range of ages that of families that we've been working with. There are on average 2 children in the home already when we're assessing families for ACEs. Among folks that have been assessed through our SCAN assessment, we have a high number that are reporting depression. So 52% report sometimes, always, or frequently feeling depressed. The majority of family members that we have screened do report very good, or excellent health. This shows the ACE scores that we're finding, and again, the number assessed is 134, and you can see that about 20% or 19% are reporting no ACEs. There we go. Okay. Thank you.
That's our correct
slide. We apologize for the technical difficulty there, but we have about 20% that are reporting no ACEs. 41% are reporting 1 to 3 ACEs, and 25% are reporting 4 to 6 ACEs. 13% are reporting 7 or more. So about 38% or over 1/3 are reporting 4 or more ACEs, which really is, in the original Kaiser study, really tips the scale towards a greater increase of adult health problems, chronic health conditions. As Kaitlin mentioned, we also administer a resilience measure called the Connor-Davidson Resilience Scale. This is a 25-item measure, and the average score in a normative population in the U.S. is 80.4 out of 100 total points, and the average among our population is 76. And you can see that there are a fair number of individuals who have been assessed that score on the high range of resilience, so 48%. 48% are in the middle, and a small number are scoring below 50 on the 100-point scale. I will now hand it back to Kaitlin, who's going to have a few more comments.
Just to summarize and also reflect on what we've talked about, we thought that it would be helpful to leave you with some pearls that hopefully you can apply in your own setting, and also just review our major takeaway points. So first of all, we found that the overall experience has been positive for patients and for providers in participating in the SCAN program. Our preliminary findings, as well as when we initially talked to others when we were looking for models to replicate, show that one of the most impactful findings is that screening for ACEs has been very beneficial to the patient-provider relationship. We found that it actually strengthens it, and that's something that we're interested in investigating more further. We also know that the ACEs assessment and intervention through SCAN helps to increase knowledge as well as start the conversation about difficult experiences, and helps to facilitate those crucial conversations between clinicians and patients. We also know that there are things that we can do to help implement ACEs in your setting. So ideally, we would all have family resource specialists embedded in our practices, and we would all have wonderful training and capability to do this. But we realize that we live in a world where that's not always the case. So before you say, this is too much for me, I can't possibly manage this, I would like to remind you of a few things and then also give you some bare minimum things that you could do in order to implement this into your own setting. So one reminder is that this is a one-time assessment. It's once in a lifetime. You don't have to keep doing it, say, at every well child check visit. We've also found that it's not too difficult, and actually we've been surprised in the clinic that people who were not initially part of the SCAN team or involved in the project are asking to be involved because they recognize the value of it and they want to be trained to screen and to be part of this process. In order to implement SCAN, or at least ACEs assessment in your setting, at a bare minimum you need somebody who can actually conduct the assessment. This could be a medical assistant, a nurse, a caseworker, a physician, a behavioral health clinician, whatever works for you in your process. You also need a clinician who can converse about ACEs appropriately with patients. So someone who is not afraid to start that conversation or even just follow up after the assessment has been conducted. And we would recommend, too, having some training in that. And third, you need a knowledge of and the ability to refer to community resources. You don't have to have a designated person to be able to refer to community resources. As long as you're familiar with them, then that can help connect patients with what they need. And I think that's also useful to remember that one of the barriers to addressing these difficult subjects and broaching these topics is that we worry about time and that you're going to open up a can of worms and asking about someone's trauma history or a difficult experience or learning about their ACEs score. The important thing to remember is that we're not asking you to fix it. You have resources to help and resources to refer out to. But this is an important part of strengthening your relationship with your patient and helping them to understand and improve their health. And then lastly, we would recommend education and training for all of your employees in your setting so that everyone understands and appreciates and can provide a trauma-sensitive setting. So even though the SCAN project is in its youth and the data are still being collected, we're very confident that we found this program to be worthwhile and that we'll continue to score, connect, and nurture our patients. We're hoping that you have found some useful information in this webinar to be able to apply in your own setting. And now we will open it up for questions, and as well as we have a resource slide here in case you would like to contact us for more information, or there are some wonderful ACEs-related resources available.
Hi, Kaitlin, can you hear me?
Yes, I can.
Very good. Thank you, Dr. Leckie and other panelists. This was an amazing webinar today. We do have a couple of questions that have been submitted throughout the course of the webinar, but it looks like we have about 10 minutes left. If others on the call today have questions, please feel free on the navigation bar on the right-hand side of your screen. There's an opportunity to type in some questions, or if you'd like to raise your hand, I'd be happy to unmute you, and you can ask that question verbally. So panelists, the first question we have is from Kathleen Rhymes, and she says, important work. Was there any follow-up assessment of parenting practices, improved resilience, or behaviors of children of those parents with greater than 4 ACE scores? So again, was there any follow-up assessment of parenting practices, improved resilience, or behaviors of children for those parents with greater than 4 ACE scores?
That's a great question. We, as Kaitlin had described and others described, one of the primary goals is to have parents receive evidence-based parenting programs such as Safe Care and HIPPY, other programs that are dedicated to early childhood. And we are linking data as far as knowing which parents followed up with those resources. So we'll be able to show the number of families who received a SCAN assessment, were referred to a parenting program, and then received that parenting program. But at this stage in our pilot project, we won't have the resources to really look at their outcomes specifically related to SCAN, but in our next formation of this, that is part of our goal.
Catholic Charities is actively trying to help pull our midpoint data now in terms of what percentage of families were referred that actually attended one or completed a program.
Very good, thank you. Our second question comes from Brian DeSantis. Brian asks, in regard to your family practice residents, how long are their well child checks? And on average, how many encounters do they see a day? Which is the first part of the question. And then secondly, if an ACEs assessment is being conducted, is the duration of the well child visit extended at all?
So let me just clarify. He wants to know time, number of visits, and if it's extended?
Yes.
Okay. So our typical visit schedule is either on a 20 or a 40-minute block. Our well child checks are blocked out at 20 minutes each. That doesn't exactly work the same as it would in private practice, though, because there's a kind of a maximum number of patients in a half day that a resident can see based on their level of training. So our second years typically see a maximum of 8 patients in a half day, 6 to 8, and we have a pretty high no-show rate in that. And then our third years may have up to 10 or 12 booked in a half day, but that is unusual. So it was recommended by one of the interns, actually, that we do bring patients in early to have the scan assessment completed ahead of time. However, we have not implemented that because the overall consensus by some of our more efficient and older residents is that it doesn't affect workflow once you get into that habit. So our first years that already sort of struggle to see patients in short time slots are finding it difficult to complete the ACE assessment in addition to the rest of their work. Our upper levels and some of our second years are not finding that to be difficult or a time constraint at all. Does that answer your question?
I think that provides a good response. The next question, I think you responded to this in one of the previous questions, but do you know how many patients followed up on your referrals to community resources? I believe that's in process right now, right?
Polly, we're experiencing a little echo, I think. Can you repeat the question?
Or type it to us, or we'll say it.
Sure. Let me try it verbally one more time.
Okay.
Do you have an idea of how many patients followed up on your referrals to community resources?
Okay, so and not at this time. We're working on mining that data for our midpoint. We will have a better idea soon. We're working with Catholic Charities, which is one of the primary places where we refer patients. So they'll have some of that data available for us, but at this point we do not have it.
Okay. Kaitlin, can you hear me now?
Yes.
Okay.
Yes.
The next question is, what sort of trauma-informed care training do you do for your frontline staff to sensitize them to the ACEs issues?
So that primarily involved, first of all, increasing their awareness and knowledge of what ACEs are and what it means to be trauma-informed, and really approaching patients as, instead of what's wrong with you, really more what happened to you. So I would like to see us do more training related to this, but the primary way that we've done that so far is what I was referring to with the level 1 training, where the option to participate in the ACEs assessment anonymously was provided, and we kind of processed what that means for our patients and for ourselves when you have so many ACEs, and how we can approach families in a way that is sensitive to them and to their needs. Anything that you guys want to add to that? Oh, of course. Go ahead.
The level 1 training also does include sort of a similar introduction to this presentation where we just talk about how ACEs are linked to health and give them some of the statistics and a very brief sort of medical background of how the two are related.
Very good. Thanks, guys. Next question. Where do you document the ACE scores within the child's chart, parents' charts, or all of the above?
Excellent question. We at this time are documenting pregnant patients' ACE scores in their chart. That one is pretty straightforward. On our Well Child Tech clinics, a parent's ACE score is being documented in the child's chart because in many instances the parents are not our patients anyway. We have run into some pitfalls with that. For example, if the same family brings two kids in on separate days, we attempt to screen them a second time, not realizing that we already have an ACE assessment on that set of parents, and it's just scanned into their other child's chart. So we try to go, I guess, get that back out and then scan it into the second child's chart. We're currently putting it under health maintenance, and then we're having the providers document it in their plan, what the score was and if it was addressed. But our current EMR is not ideal, and we're in the process of a system of changing to a new one, so they're not really interested in accommodating us at this time.
We would like to see a better, more useful place where we could more easily access that score in patients' charts. Right now, the primary way is that we have a summary sheet that gives the date and summary score of the ACEs assessment as well as their resilience screening score and any resources or interventions that were provided to them. And then that document is scanned into the patient and or child's chart.
I imagine it would fit very well in a social history. If you had an EMR that the social history was visible from while you're conducting or while you're performing your next visit and doing your next note, and it would populate forward so that the provider could check in on it.
Okay, next question. Do you ever ask the parents to complete the ACE score for their child?
No. So the ACEs screening is primarily for people who are above 18 years old, just largely because the prompt question is prior to your 18th birthday. Did any of these categories of things happen to you? So we have patients often respond when they're filling it out for themselves that, oh my gosh, my child has already been exposed to some of these. But we normally do not assess for the children or their summary score.
Unless it's a 16 or 17-year-old pregnant patient.
Mm-hmm. Very good. The next question relates to the project generally. What was the time frame from the conception and training of this project to the actual implementation?
So this is Julie. We started planning to apply for funding about probably 8 months prior to obtaining funding. And by that I mean we were meeting with clinic staff and leadership around wanting to get a project like this going. Then once we were funded, the family development specialist was hired and started in August of last year, and we were assessing families in October of that year. The training is ongoing because we found with residents in particular and being in this setting that when we provide a training, there are folks who cannot make it, who had planned to come and they are called out on to see a family or just weren't able to attend. So We have provided training ongoing, and each year we will also have new residents that come in, and so that will be part of our future plan as well.
Very good. Next question. Are you able to bill for the ACEs screen or encounter?
You cut out just a little bit.
I think it's
Oh, sorry guys, I'm having audio problems. Let me try again. Are you or were you able to bill for the ACEs screen or encounter?
Not as a separate code. We continue to bill for the physician's time in a well-child check visit. Residents cannot bill time codes. An attending physician or someone in private practice could essentially bill up code based on the amount of time they spent with the family, but there's not a separate code for it the way there is for 10 minutes of tobacco cessation, for example.
Very good. So panelists and attendees, we have many questions today, more than I think we're going to be able to get through in the next 2 or 3 minutes that we have left. Please know that I will forward all of the remaining questions to our panelists, and we'll have a means of being able to respond to those either via email or on the website. For those of you who this is your first CFHA webinar, or you're not familiar with our organization, again, we have a Families and Health Special Interest Group that meets quarterly. The topic... I
don't know if we have the same technical difficulties that Polly is, but just in case she doesn't come on, thank you all for attending. And I think she was assuring us that your questions will be forwarded and we will answer them in a timely fashion.
Thank you all.